I am Sudhisha Jala, and I am a physician assistant. I have been practicing in GI and hepatology since graduating from PA school in 2017. I started off working inpatient for several years and have been outpatient for the last year. Rachael and I are excited to be doing this podcast on PBC. We are going to be talking about managing PBC symptoms in the real world, as well as some helpful tips for APPs.
Yes, I am Rachael Bierschenk. I am a nurse practitioner. I have been practicing for the last 11 years, and I've been with our practice for the last 9 years, specifically in GI and hepatology. So we're going to get straight into it. We know that fatigue and pruritus are the most common and debilitating symptoms for our PBC patients. So, Sudhisha, what are your top 2 practical non-pharmacological strategies that you recommend to your patients in your clinical practice?
2 non-pharmacological therapies I would recommend for pruritus and fatigue are light therapy and exercise. There's actually a couple of different types of light therapy, and I will discuss each one briefly. There is UVB or ultraviolet light therapy, and this works by using a light therapy box that emits bright light for a period of time. It's usually about 15 to 20 minutes, and patients do this a few times a week. They can do this for several weeks. This type of light therapy is phototherapy, and it helps primarily with itching. The second type of light therapy is bright light therapy, and you can also use a light therapy box for this. This would be non-UVB light, and for this one, it is important patients do this daily. They can do this light therapy for 20 to 30 minutes each day. Every morning. It is better if it's done in the morning. And this type of light therapy will help specifically with fatigue. It can also help reduce daytime sleepiness, and it can help improve patient sleep at night. Some patients can actually see improvement in as little as 2 weeks, which is great. The next type of therapy I would recommend for fatigue that's non-pharmacologic is exercise. So exercise, great for everyone, great for all different types of health problems. For our PBC patients specifically, it is going to help with fatigue. The type of exercise we typically recommend is low impact aerobic exercise. It is best if it's done regularly and if patients gradually increase. I would say some good examples would be walking, yoga, and swimming. This can all definitely help increase energy, help their mood, and help with sleep. I'm going to move on to the first question for Rachael. What are the most common challenges you encounter in ensuring patient adherence to PBC treatment plans? And how do you address patient concerns about long-term medication use or side effects?
Yeah, so one challenge that I have with PBC patients are my asymptomatic patients. We know that about 50% at the time of diagnosis, they're actually not going to have any symptoms. So they get this incidental finding of an abnormal lab, and now they're being sent to a specialty provider, and they're being told that they have this chronic condition that's going to require lifelong follow-up and lifelong medications. I think we've all had those patients who don't want to take any medications unless they absolutely have to. They may bargain and ask to start a new start treatment if they develop symptoms or once their labs worsen. I explain to these patients that we know from data and research that the disease can be what I consider a sneaky disease. Symptoms, as well as the level of their alkaline phosphatase, doesn't always correlate with the disease severity. So adherence to follow-up appointments for training of their labs is really pertinent to their care and helps us as providers to be able to better tailor and adjust their treatment plan for better outcomes. Unfortunately, like other chronic disease processes, medication is the only treatment that we know, at least for PBC, to help slow the progression of the disease and hopefully prevent the development of cirrhosis. It wasn't too long ago that the nomenclature was actually changed from primary biliary cirrhosis to primary biliary cholangitis. We're not able to reverse or cure this disease. So, reiterating to that patient that without compliance, so with our medication and follow up, the risk of disease to end stage cirrhosis is always a potential. As for the side effects of medications, overall, I've seen a low discontinuation rate due to side effects. Most commonly is diarrhea, but typically gets better over time as the body adjusts to this medication. There's always other options to maybe decrease the dosage or to change the frequency for their better tolerance are other options. As for the concern for long-term side effects from taking these medications over several years, I think we can confidently say that the most commonly prescribed drug, the ursodeoxycholic acid, has been well studied and approved by the FDA since the 1980s for dissolving gallstones and even since the 1990s for PBC in the United States. The next topic for Sudhisha is, besides the ursodeoxycholic acid, what pharmacological interventions have you found most effective for managing refractory pruritus, and how do you navigate those potential side effects?
So there are some other treatment options for pruritus and refractory pruritus, and I'll discuss those. One is a bile acid sequestrant. So this is a category of medication that has been around for quite some time. It can really help some patients itching. It is relatively easy to get, so maybe worth trying. You can add a bile acid sequestrant to ursodeoxycholic acid. It is important just to know that it does need to be given 2 to 4 hours before or after the ursodeoxycholic acid. There are a couple of side effects from bile acid sequestrants. The more common ones patients experience are constipation, and sometimes bile acid sequestrants can interfere with absorption of fat-soluble vitamins. 2 other medications that we can try specifically for refractory pruritus is an SSRI or a barbiturate. Like any drug, they do have some potential for side effects. Barbiturates can cause somnolence, not great in our patients who are already fatigued. And then hypotension and bradycardia are 2 other side effects they have. SSRIs, there's a lot of different side effects. They can cause nausea, changes in weight, diarrhea, headaches. It is really important to look at your patient's entire medical history and discuss any potential side effects from medicines they may start before you actually prescribe one of these therapies. I think a lot of these patients that are having severe itching are probably at a point where they're willing to try anything, but again, depends on each patient. There are a few other treatments I am going to discuss that are now FDA approved for PBC, and again, these can also help with itching. So these are obeticholic acid and a PPAR agonist. Both of these can be used as monotherapy or added to the ursodeoxycholic acid. A patient who may not be tolerating the ursodeoxycholic acid, or if their alk phos level hasn't come down, these are other reasons other than itching why they may have one of these newer therapies added. I will mention these medicines are all contraindicated in patients with decompensated cirrhosis. With the obeticholic acid specifically, it does ironically have a side effect of itching. So me personally, I probably wouldn't use that as my first choice for a patient with refractory itching, but it could help someone. And we have so many treatments now for PBC, more than we ever did before. So I did want to mention it. There are very new PPAR agonists. And again, these can both be used in conjunction or as monotherapy. And one in particular has shown rapid improvement in pruritus. So this could be a really good option for one of your patients with refractory itching. Abdominal pain and nausea are potential side effects of the PPAR agonists. Since they are newer, we will probably have to give some more time just to see more long-term studies, but the studies that we do have do show them to be really promising. Ultimately, I think if we can get a patient's itching under control on one of these therapies, we can figure out anything else that we need to do for potential side effects, but getting the itching under control is really important since it affects their quality of life so much. Lastly, I will mention if none of these therapies work for refractory itching, then at that point, we will consider sending them for liver transplant evaluation. Moving on to the next question for Rachel. How do you differentiate PBC-related fatigue from other potential causes? And when do you decide to refer to other specialists, such as sleep medicine?
So I think a good starting point would to make sure that our current treatment is being effective. And so that's when we start with the labs and we check their alkaline phosphatase levels. And if these levels have improved or even normalized, our treatment that we're giving them is working. And so their fatigue should be ideally getting better too. So if not, it may be related to some other process. So there can be some overlap in PBC because it is an autoimmune process and they often have secondary autoimmune conditions. One that is associated with PBC and fatigue is autoimmune thyroiditis. It is recommended to screen our PBC patients yearly with a TSH level. And if this is abnormal, then it is recommended to refer them to their primary care physician for further management, and they may see the improvement. Other conditions that come to mind is sleep apnea. Daytime sleepiness, even with good night's sleep, could mean that they have an underlying sleep apnea. Does your patient have risk factors such as obesity or an extra fat or a thick neck? Then it'd be reasonable to refer these patients to pulmonology or sleep medicine. Another basic workup would be just to check their labs to rule out anemia. We know that can also cause fatigue. Or are there any new medications? Review those medications. They often cause fatigue, such as beta blockers, statin therapies, antidepressants, or maybe someone gave your patient an antihistamine that we know doesn't help this type of itch and pruritus, but we know that they have a side effect of fatigue. Other potential referrals would include rheumatology for symptom overlap with another autoimmune disease such as Sicca syndrome, and these patients will report dry eyes and dry mouth.
It sounds good. And lastly, how do you feel that APPs are uniquely qualified to manage PBC patients, and what advice would you give to other APPs who are managing patients with PBC?
So I think as advanced practice providers, we are well equipped with the tools to manage PBC patients. We don't just treat the disease, but we focus on the person as a whole. And we tend to spend more time with our patients and we are actively listening to their concerns. Some advice to our listeners and viewers, I would say with like any other rare disease, we need to try to keep up to date with newer therapies and treatments just to continue our education with either CMEs or podcasts. So we can just advance our knowledge. And then with that knowledge, we're more informed and more educated and more confident to be able to treat our patients. And the patients are going to feel that too from you if you have this confidence to be able to talk to them about the disease and how we can manage them. So use your resources, network of colleagues to help coordinate your care. So thank you all for listening to our PBC podcast. We hope that it was helpful. And we would like you to please visit the GHAPP website or the GHAPP ACE app for more information.